ఏమి ఇదేంటి నైట్ డ్యూటీ చేసాడా?
లీవ్ పెట్టాడు సార్. నేను మాట్లాడతానులేండి సార్. అయితే నో ప్రాబ్లం. సరే, 10 మంది జనవరి స్టార్ట్ చేద్దాం సార్.
అలాగే.
హలో హలో
గణేష్
సార్, వినిపిస్తుంది సార్?
వినిపిస్తుంది.
ఓకే సార్. హలో.
యా ఓకే
సార్, స్టార్టింగ్ సార్.
చెప్తాను. మోహన్ రావు సార్ ఫోన్ చేసావా?
ఇందాక 7:30 కాల్ చేసింది సార్.
ఏమన్నాడు?
గుడ్ మార్నింగ్ సార్.
గుడ్ మార్నింగ్ సార్. గుడ్ మార్నింగ్
సార్ గుడ్ మార్నింగ్.
మోహన్ రావు మీకోసం వెయిట్ చేస్తున్నాడు.
లేదు సార్, మెడికవర్ నుంచి అన్ని న్యూరో క్రిటికల్ కేర్ వస్తాయి సార్. మెడికవర్ నుంచి అన్ని న్యూరో క్రిటికల్ కేర్ వస్తాయి.
ఎందుకని?
మేము పెట్టుకున్నాం.
అంటే దానికి ఏమైనా ఉందా? 1 year న్యూరో క్రిటికల్ కేర్, 1 year నెఫ్రో క్రిటికల్ అలాగా?
ప్లాన్ చేస్తున్నాం.
మాకు ఎక్కువ సార్.
అలా పెట్టారా?
చాలా ఎక్కువ కేసులు ఉంటాయి.
లాస్ట్ టైం ఐసీబీ మీద చెప్పాడు సురేంద్ర.
అవును, న్యూరో క్రిటికల్ కేరే చెప్తారా, ఇంకా వేరే కూడా చెప్తారా?
టాపిక్స్ 11 12 టాపిక్స్ ఉన్నాయి కదా,
అవన్నీ అయిపోయినాక
మిగతా చెప్పడానికి మీరు ఉన్నారు కదా సార్.
అంతే, మీరు చెప్తాం వేరు, మేము చెప్తాం వేరు కదా సార్. స్టార్ట్ చేద్దాం సార్. Good morning all. Today Dr. Ganesh is going to talk on approach to unconscious patient. He is a new consultant working in the medical hospital. I request Dr. Mohan Rao to introduce the speaker.
Good morning everyone. Good morning Dr. Mohan Maharaj and Dr. David. Thank you for the opportunity. Dr. Ganesh recently joined in our team. He did MBBS and MD anesthesia in Andhra Medical College. After that, he did his DRNB in critical care from Care Hospital, Banjara Hills, Hyderabad, under Pawan. Is a very young and enthusiastic, very dynamic intensivist. We thought this is we day in day out we are getting cases in intensive care with coma patients. So we have allotted this topic to the Ganesh. I hope he will justify the for this topic. Over to Ganesh.
Okay, sir. Thank you, sir. Hello, everyone. I'm Dr. Ganesh, working consultant in medical hospitals. And today's topic, I'm going to explain about the approach to unconscious patient, that is the comatose patient. And I prepared the slides keeping in mind about the residents. It's basically important, and brush up of knowledge of the consultants, ongoing practicing consultants. Why this topic is important? Because it's caused by a spectrum of disorders, mostly by the both medical and surgical causes, and both primary and metabolic or systemic causes also. And it's a potentially life-threatening, so it is a neurological emergency. So if we can recognize the cause that is a reversible cause, we can treat early and can prevent the secondary injury. So dictum is speed is essence in diagnosing and approach of a comatose patient. So what are the goals of care in comatose patient? We have to rapidly determine the type of mental status change, whether it is a hyperacute or acute and subacute as chronic. In hyperacute and acute, if you do any intervention, we can prevent secondary injury and timely administration of the life support measures where urgently needed, like uh, giving Mannitol or 3% for riser ACP or for symptomatic hyponatremia, we have to give 3% correction, for giving ventilator support for patients of low GCS less than 8, and any surgical consultation for the riser ACP, like massive bleed or herniation syndromes. And before that, we have to go treatment along with the proper history and workup also. All should be go hand in hand. And obtaining the detailed history and physical examination directed at determining more precisely the cause of nervous system disorder and selecting appropriate and informative diagnostic and laboratory studies. We have a series of investigations for approach of a comatose patient. So no need of doing all the investigations based upon the clinical presentation, which will help in diagnosis. We have to do the investigation. No need of doing all the CT, MRI, EEG, all those things. We have to limit our investigations based upon the clinical presentation. And final step is initiating the definitive treatment and based on the assessment. Coming to the applied physiology related to the consciousness. Consciousness refers to the state of full awareness of self and self's relation to the environment, which depends upon intact arousal and content. Arousal is the level of attentive wakefulness and readiness to respond to relevant sensory information. Alerting stimuli, that is visual, auditory, touch, all these are the alerting stimuli. All will rely on the uh, ascending reticular activating system, which is present in the pons and midbrain, and they relay into the thalamus. From the thalamus, they relay into the cerebral cortex. So, if there is any damage to this ascending reticular activating system and diencephalon, that is thalamus and hypothalamus and cerebral cortex, the patient will be presenting with the features of altered sensorium or comatose patient. So if the patient having any focal deficit, only unispherical involvement of the cerebral hemisphere, only one lobe of the cerebral hemisphere is involved, then he won't present with the altered sensorium. For the presence of altered sensorium, the patient should have bilateral cerebral hemisphere involvement. So I already explained that this visual impulse, touch impulse, pain, temperature will ascend, and they got reticular activating. All the got synapses in the reticular activating system in the brainstem. From the brainstem, they relay into the hypothalamus and thalamus. From them, it will go to cerebral cortex. So, what is meant by attention? Is the patient's ability to attend a specific stimulus without being distracted by extraneous internal or environmental stimuli. For suppose if you are using this class, if you can hear that outside sounds that we are not attentive, this selectivity is associated with unawareness of a great deal of irrelevant stimuli and memories. The patient is having sustained attention, then it is called concentration. So the patient is having sustained attention is called concentration. So what defines coma? A state of unresponsiveness in which a patient lies with his closed eyes and cannot be aroused to respond appropriated to stimuli, even with vigorous stimulation, that is suprasternal rub or deep suprathreshold stimulus, or by pinching the nail bite, all those things. We are giving the extra stimulus also, the patient is not responding. The patient may grimace in response to painful stimuli and limbs may demonstrate stereotyped withdrawal responses. But the patient does not make localized responses or discrete defensive movements. So for suppose if you are sleeping, if we have any stimulation, will be withholding the stimulation. We will be moving away. If you have touched with the heart stimulation, we will be moving away from that. The patient, if anyone pinches us, if we are awake or asleep, if anyone pinches us, we will be pushing his hand. This response will be absent in the comatose patient. So in simple term, is defined as a comatose if they have no ability to take in information from the environment and cannot respond to external stimuli in a meaningful way. So for the patient to present in comatose patient, the lesion should be involve the reticular activating system and bilateral frontal lobe involvement, bilateral temporal lobe involvement, and diencephalon. So how to logically approach a comatose patient? First, we have to rule out the coma mimics, and next, whether brainstem is involvement or it is hemispheric problem. We can know that it's a brainstem involvement problem by assessing some cranial involvement and breathing pattern changes. By that, we can say, okay, the patient is having brainstem involvement. And if there's brainstem involvement, it is primary or it is secondary. Second is because of any coning. If it is hemispheric, it is structural or metabolic. And finally, the group of investigations and management and prognosis. So we will be approaching the comatose patient these 5 steps. So the differential diagnosis: locked-in state, akinetic mutism, persistent vegetative state, catatonic stupor, pseudocoma, and abulia. Before going into that, we can grade the level of consciousness based upon the stimulus needed for arousal. If the patient is, if the person is alert, it is based upon the patient is, if the person is awake and is oriented and following all the commands. If you describe the term drowsiness, you will be lethargic but arousable to verbal and light touch. Even obtundation, you will be responding only to the deep touch, not with the verbal or light touch. In stupor, is because of noxious stimulus, whereas in comatose, withdrawal of reflexes or abnormal posturing, or there is no response to the vigorous stimulus also. So alertness, drowsiness, obtundation, stupor have meaningful responses, and in this comatose patient, they doesn't have meaningful responses. So based on this, we can grade the patient based on the level of consciousness. So this is wakefulness, and this is the x-axis showing wakefulness, and the y-axis showing the content of consciousness awareness. Based on that, we can classify in the extreme low wakeness, absent of wakefulness, and absent of awareness, it is comatose. Then general anesthesia also. So we have to mimic. First, we have to rule out giving sedative and paralytic agent, and after that, deep sleep and light sleep, drowsiness, locked-in syndrome, and consciousness. This is a spectrum of with increasing wakefulness, we can see that from the patient moving from the coma to the consciousness. And in minimally conscious state and vegetative state, patient will be wakefulness, but will be having less awareness. So in locked-in state, by definition, is alert and aware, and is quadriplegic with lower cranial palsy. The lesions will be involved in the bilateral ventral pons. Close differential diagnosis will be myasthenia gravis, polyneuropathies, and neuromuscular blockers. In persistent vegetative state, the patient will be having absent cognition, preservation of vegetative function. The lesions will be having extensive cortical and subcortical lesions with preserved brainstem. Example remarks: the differential diagnosis will be coma vigil and cerebral coma death. In abulia, the definition is apathy, neither speaks or moves spontaneously. The lesion will be involving the bilateral medial frontal lobes. The differential diagnosis will be akinetic mutism. In catatonia, patient will be mute, decreased psychomotor activity. There will be no lesion. We can be differentiated by the EEG. Close differential diagnosis by the frontal disease or drugs. So based upon the arousal, awareness, sleep-awake cycle, and motor response and respiratory movement, we can differentiate between the brain death, coma, vegetative state, minimum conscious state, and akinetic mutism, delirium, and locked-in syndrome. In brain death, in coma, they doesn't have arousal, awareness, and sleep-wake cycle, and motor response is completely absent in brain death, whereas in comatose patient, it will be having non-purposeful movement. How to differentiate between the brain death and coma? If the involvement of the medulla, also that is involvement of cranial nerve 9 and 10, then we can suspect in brainstem analysis, in brainstem function analysis, the patient is having involvement along with the medulla, midbrain and pons involvement, along with this cranial nerve involvement of 9 and 10, which lies in the medulla, we can suspect brain death. So any comatose patient, we have to assess for the brainstem reflexes to ascertain brain death. The patient doesn't fit into the brain death criteria, we have to treat as a comatose patient. Whereas in vegetative state, he will be having arousal, he doesn't have awareness, and sleep-wake cycle will be present, and there will be non-purposeful movement. In minimal conscious state, it will be arousal, and awareness will be partial, and sleep-wake cycle will be present, and with intermittent purposeful motor response will be present. In akinetic mutism, arousal will be present, partial awareness will be present, and sleep-wake cycle present, and paucity of motor response. In delirium, it will be arousal, awareness will be partial, and sleep-wake will be present, and motor response will be normal. In locked-in syndrome, arousal awareness will be present, but it will be quadriplegic, and sleep-wake cycle will be present. So based upon the level of arousal,
రిపీట్ చేయవా అది కొంచెం డిఫరెన్సెస్ కొంచెం రిపీట్ చేయవా
ఇక్కడ నెక్స్ట్ స్లైడ్ సార్, నెక్స్ట్ స్లైడ్ లో చూపిస్తాం సార్. బ్రెయిన్ డెత్ కామాలోని, ఇన్ బ్రెయిన్ డెత్ అండ్ కామా, doesn't have arousal and awareness, and sleep-wake cycle will be absent, sir, and you will be having non-purposeful movement. Whereas in brain death, it doesn't have any non-purposeful movement. In vegetative state, you will be having arousal response with no awareness, and sleep-wake cycle will be present, and you will be having non-purposeful movement. Whereas in minimal conscious state, you will be having arousal response, but awareness is slightly better than, will be slightly present, and you will be having sleep-wake cycle. In akinetic mutism, you will be having arousalness and awareness with sleep-wake cycle with paucity of motor response. In delirium, it is a acute state with arousal will be present with partial awareness with sleep-wake cycle, and motor response will be normal. In locked-in syndrome, you will be having arousalness and awareness with sleep-wake cycle with quadriplegia. So in this, arousalness and awareness will be fully present. In coma, sleep and anesthesia, absent of arousal and awareness. In vegetative state, arousalness will be fully present and awareness is absent. In minimally conscious state, arousal is fully present, but awareness is slightly better than the vegetative state. In locked-in syndrome, you'll be having both arousal and awareness. So we can have three types of presentation: the delirium, somnolence, and agitation and psychosis. Delirium is most commonly caused by infections, toxins, and sedative withdrawal and hospital-acquired delirium. You'll be having wide fluctuation of course during a day. Rather than somnolence, we'll be having metabolic and CNS infections and structural causes of raised ICP and toxins and sedative intoxication and stimulant withdrawal. These are the most common causes of somnolence. Whereas in agitation and psychosis, we have to rule out CNS infections, steroid use and stimulant intoxication, sedative withdrawal, and primary psychiatric disease. So how to differentiate between delirium and dementia? It is acute and it is subacute. It is mostly acute to subacute onset, whereas the dementia is a chronic and progressive onset. And the characteristic feature of the delirium is a fluctuating signs, whereas in dementia it is consistent signs and usually reversible the delirium and irreversible in the dementia. So before you should take a proper history. Before we have to know what are the causes of coma, so that we can look for those signs and symptoms in a particular patient. So the proper history is very important. It's often difficult and sometimes impossible to obtain. First history is important is the rapidity of the onset, acute or subacute. For example, if acute, we can say any IC bleed, any cerebral infarct, massive cerebral infarct, we can suspect acute, or hypoglycemia is acute. Whereas subacute, mostly the metabolic cause, hepatic encephalopathy, uremic encephalopathy, and hypoxia, hypercapnia that doesn't present initially, it will progress over a course of time. And subdural hemorrhage is one of the neurological cause which present with subacute, and meningitis is also one of the causes of subacute. And symptoms prior to the coma, whether it's any trauma, so that we can EDH, SDH, or ICU bleed, we can suspect, or headache, subarachnoid hemorrhage, meningitis, or history of fever for septic encephalopathy, or any CNS infections like encephalitis, meningoencephalitis, brain abscess, or seizure disorder. This bilateral cerebral cortex involvement will present with comatose patient, and chest pain and breathlessness, and history of neurological deficit. Focal cause, mostly it is a neurological cause, and the patient is having diffuse symmetrical weak presentation. We can suspect systemic causes. In the past history, we have to look for diabetes. A patient may prone for hypoglycemia, hypertension may present with hypertensive encephalopathy plus syndrome, or it can be cause of the ischemic stroke or IC bleed. And alcoholism, they can alcohol intoxication or Wernicke's encephalopathy, or seizure disorder, or drug abuse like opioids, SSRIs, and MAVA inhibitors, and depression or suicidal attempts. We have to ask this history and drug history, whether the patient is having, we should ask for the drug history like SSRIs, all those things. And general physical examination, the appearance of the patient, the evidence of trauma, ligation marks on neck, or evidence of hepatic or renal dysfunction like icteric presentation, pedal edema, or uremic smell, or incontinence and tongue injury, suspect seizures. And if you find needle track, you have to suspect drug overdose, and cyanosis like hypoxia, cardiac disease, and cyanotoxicity. And cherry red, that is the carbon monoxide intoxication. In icterus, mostly hepatic disorders and hepatic encephalopathy and hemolysis. You can see in the malaria, one of the most frequent cause of altered sensorium with fever prodrome in our centers, and pallor for anemia, hemorrhagic shock, and vasomotor syncope. And PTK, we have to look for DIC, ETP, and meningococcemia. These are the infections which can present with altered sensorium, and drug and fat embolism, and purpuric rash, meningococcemia, and tropical fevers. But look for the maculopapular rash, the toxic shock syndrome, and bacterial endocarditis in SLE. In bullous lesions for drug overdose, flushing in erythema, and polycythemia, fever, and alcohol intoxication, and bruises like trauma or patient on the anticoagulations, and sweating in the fever and hypoglycemia. So we have to measure blood pressure. Based upon the blood pressure, we can classify some causes. Hypertension, mostly stroke, will be present with hypertension. Intracranial hemorrhage, increased ICP, hypertension, encephalopathy, renal disorders, and press. These usually present with the hypertension. And neurotoxicosis also will present with hypertension. With hypertension, with hypovolemia, myocardial infarction, intoxication, ethanol and barbiturates, Wernicke's encephalopathy, sepsis, and hypothyroidism, all can be present with the hypertension. A tricyclic antidepressant can present with hypertension also. As a respiration, we have to look for the breath, or the acetone breath as DKA, or ethanolic breath intoxication, pater hepaticus, hepatic encephalopathy, uriniferous, the uremic encephalopathy, garlic odor, arsenic poisoning, opiate poisoning is common in our setup, and household gas like carbon monoxide. So if the patient is having this type of breath odor, we have to suspect this history. Based upon the respiratory pattern, we can classify two causes, hyperventilation and hypoventilation. Hypoventilation, mostly the overdose and myxedema coma. Hyperventilation, hypoxia, hypercapnia, acidosis. Acidosis, we can suspect DKA and alcoholic ketoacidosis, and methanol poisoning, salicylate poisoning. All this comes under the metabolic acidosis cause of metabolic acidosis with unconsciousness, fever, liver disorder, or sepsis, pulmonary embolism, toxins, salicylate poisoning, drug-producing metabolic acidosis, and central neurogenic hyperventilation. These are the causes of hyperventilation in a comatose patient. Coming to the temperature, hyperthermia and hypothermia, infection, inflammation, anticholinergics, subarachnoid hemorrhage, hypothalamic lesion, heat stroke, thyroid storm, malignant hyperthermia. These are the diagnostic clues for Whereas the hypothermia, exposure, sepsis, shock, myxedema, coma, Wernicke's encephalopathy, drug intoxication, hypothalamic lesion, hypoglycemia will present with hypothermia. So how to assess consciousness? Most commonly used score is Glasgow Coma Scale. It has many advantages as well as disadvantages, because it doesn't consider pupillary examination. It doesn't consider brainstem reflexes. Advantage is easy to use and good predictor of prognosis and less inter-observer variability. So we have to take the best eye opening, best verbal response, and best motor response. The main drawback is we can have permutation combination. So the GCS is less than 8. So the patient, we cannot definitely say that the patient is require ventilator support, because if the patient is having eye opening E4, V1, and M3, we cannot say. So better to individualize the exact response, so that we should say the eye opening is spontaneous and this patient is having inappropriate words and moves to localized pain, not like E3, V4, M3. We should exactly say the exact response. If the patient is having left cortical stroke, the patient will be aphasic, so we cannot assess the verbal response. So there are many drawbacks, but because of easy to use, it is most commonly used. And next score is the 4 score, which is better than the GCS, but very difficult to use by the most of the clinicians, and mostly the intensivist and the neurophysicians, will be using this score. Eye response will be 4 to 0, and motor response will be 4 to 0, brainstem reflex will be 4 to 0, and respiration will be 4 to 0. By the initial assessment of the 4 score, we can assess whether the patient is having brain death also, because it includes the brainstem reflexes. So eye opening, if the patient is score of 4 will be allotted with eyelids are open and is tracking or blinking to the commands, and score of 3, eyelids open but not tracking. Score of 2, eyelids closed but open to loud voice. Score of 1, eyelids closed but open to pain. Score of 0, eyelids remain closed with pain. Whereas motor response, thumbs up, fist up, peace sign, localizing to pain, flexor response to pain, extensor response to pain, and no response to pain or generalized myoclonic status. Whereas brainstem reflexes, score of 4 for the pupillary corneal reflexes are present. A score of 3 when pupil is wide and fixed, and score of 2 when the pupillary and corneal reflexes are absent. A score of 1 when the pupillary and corneal reflexes are absent. A score of 0, absent pupillary corneal cough reflex. And respiration, 4 is not intubated, regular breathing pattern. Score of 3, not intubated, kind stroke breathing pattern. Score of 2, not intubated, irregular breathing pattern. Score of 1, intubated, breathes above ventilator rate. Score of 0, intubated, breathes at ventilator rate or apnea. This is the score mostly for ventilator patients. The GCS score less reliable on the ventilator patients. So if the patient is having brainstem reflex score of 0, better after illustrating patient of hypothermia and is of general anesthesia, we can assess for the apnea test for brain death declaration. So what are the signs of localizing value? Based upon the respiratory pattern, pupillary responses, limb movements, and eye movements, we can assess what is the level of lesion in comatose patient. If the patient is having abnormal respiratory pattern, that is bilateral involvement of bilateral cerebral hemisphere and diaphragm involvement, they will be having kind stroke breathing. If the patient is having lesion at the level of lower midbrain and upper pons, will be having central neurogenic hyperventilation. If the patient is having lesion at the mid level of pons, having apneusis. Lower pons will have a cluster breathing, or reticular activating system or medulla will having ataxic breathing. So based upon the respiratory pattern, we can say the patient having bilateral cerebral involvement with diencephalon and bilateral cerebral hemispheres. It's also seen in global or metabolic encephalopathy. Whereas central neurogenic hyperventilation will be seen mostly in the metabolic encephalopathy. Apnesis will be seen in bilateral pontine lesions, cluster breathing, lower pons, ataxic breathing will be at medulla, and apnea will be seen in the ventromedullary bilateral involvement. Based upon the pupillary abnormalities, we can assess the site of lesion. The lesion is at the level of diencephalon, that is hypothalamus, thalamus is the site of origin of the sympathetic nervous system. So sympathetic nervous system will cause dilated pupils. If there is a damage to the diencephalon region, pupils will be small and reactive, and it will be seen in the metabolic causes also. So both in diencephalic lesion and diffuse effects of drugs and metabolic encephalopathy will be seeing small and reactive pupils. And if they are having the unilateral dilated pupil, it's because of the compression of third nerve on that side. It's usually seen in the uncal herniation. If the lesion is at the level of midbrain, the pupils will be mid position and will be fixed. If the pupils are at pinpoint, mostly pons and OP poisoning, cholinergic toxicity, and opiates. These three should be considered. The pupils are pinpoint pupils. The lesion at the level of pretectal will be having large and fixed, and will be alternation between the normal and large pupils. So pinpoint pupils, opiates, cholinergic intoxication, fontaine damage. Dilated non-reactive pupils, cerebral anoxia, barbiturates, atropine, hypothermia, brain death. Dilated reactive pupils, pretectal lesions, stimulants like cocaine, methamphetamine, hallucinogens, anasacaria, that's pupillar asymmetry, third nerve compression from uncal herniation, and localized drug effect. There is rare hypertropium and tropicamide, and mid position that's fixed irregular, that is midbrain lesion. Based upon the eye movement, in resting position, the patient is having a continuous lateral gaze. The lesion site will be acute hemispheric or pontine lesion. Whereas the downward gaze, the lesion will be at the level of thalamic, lesions of pretectum and hepatic coma, subarachnoid hemorrhage and hypoxia. The patient is having upward gaze at resting position, will be having sleep, seizures, syncope, brainstem lesion, hypoxic encephalopathy. Whereas horizontal disconjugate and vertical disconjugate, mostly the metabolic causes should be ruled out. And third or sixth cranial palsy, intranuclear ophthalmoplegia. These are the lesions which presents with disconjugate type of eye movements. In spontaneous movement, spontaneous roving eye movement present in the bilateral cortical dysfunction with intact brainstem. Nystagmus mostly seen in the non-convulsive seizures and cerebellar lesions. Ocular bobbing will be seen in pontine lesions and anoxia, and ocular dipping will be seen in diffuse cerebral damage, and ping pong gaze will be seen with the bilateral cerebral and posterior fossa rarely, and nystagmus jerk of single eye mostly seen in the middle or lower pons lesions, or vertical microsm will be seen in the pons. So how to differentiate between the hemispheric lesions versus lower pons and toxic metabolic lesions based on the lateral gaze in the resting position? The patient looks towards the lesion that's away from the parotic side. In seizures briefly away from the lesions, we will be having preserved oculocephalic and oculovertebral reflexes. If the lesions at the level of hemispheric lesions. If the patient is having the lesion at the lower pons, he will be looked towards the parotic side and absent oculocephalic oculovertebral reflex. Based upon the absence of presence of the oculocephalic and the oculovertebral reflex, and towards and away from the lesion, we can differentiate between the lateral gaze between the hemispheric lesions and the lower pons. Whereas in toxic and metabolic cause, they have impaired vertical and horizontal movement, that is biconjugate movements. So oculocephalic reflex, we have to rule out cervical spine injury before doing this test. Normal reflex is head rotated to the right, the eyes move to the opposite side. Abnormal means eyes follow the same side. And oculovestibular reflex will be having the slow phase and cascade phase. You have to instill 50 ml of cold saline in the if you install 50 pose, the mnemonic called COWS, pose, cold opposite side and warm same side. If you install the patient, if you install cold saline on the right side, and patient is having damage on the right side, and left side will be left side will be hyperactive, and there will be slow response to the cold side, and there will be immediate fast cascade response will be there. If we're having intact vestibular response, we'll be having immediate fast response, fast cascade response. Where if we have vestibular injury, we cannot see that fast response. And fundus examination is helpful for the assessment of the altered sensorium. We can say hypertensive encephalopathy and raised ACP. In raised ACP, we can see the papilledema. In hypertensive encephalopathy, narrowing of the arterioles, exudates, we can see. You can see meningeal signs for meningitis, subarachnoid hemorrhage, and cerebellar herniation, Bunchkin sign and Kernick signs, and necrologity. All these three signs will be present in meningitis, subarachnoid hemorrhage, and cerebellar herniation. Coming to the motor examination, it's difficult to interpret. Mostly the light comatose patient lies quietly or thrashes about in bed. They can be present with decorticated rigidity and decerebrate rigidity. Most common responses are reflexive in reaction to noxious stimuli. Localizing responses such as moving the examiner's hand away from the body are not consistent with the coma, and flexion extends response to painful stimuli are consistent with coma. So based upon the posturing, we can also say that the level of lesion. In the decorticate lesion, the lesion will be above the red nucleus, and decerebrate region will be below the red nucleus, that is the reticular nucleus, vestibular nucleus. So coma quick interpretation, it is caused by structural disorders and non-structural disorders. And structural will be having supratentorial, that is hemisphere, infratentorial brainstem. In non-structural, we have to look for metabolic causes. So, to simplify, first to rule out mimics of coma, whether patient is really in true coma, exclude persistent vegetative state, locked-in syndrome, mechanetic mutism, catatonic stupor, and pseudocoma. And step 2 is a brainstem involvement. Look for the pupillary change, oculocephalic reflex, other eye signs, lateral gaze, those things, and respiratory pattern. And look for it is primary or secondary to coning. So, and next, how to differentiate the supratentorial and infratentorial etiology. The initiating signs usually focal in supratentorial, where it is sudden onset of brainstem dysfunction will be seen in infratentorial etiology, and signs of dysfunction focus from rostral to caudal, that is the involvement of cranials will be the last in the supratentorial etiology, whereas localizing brainstem signs precede or accompany the onset of coma, and neurological signs at any given time point out to one anatomic area, that diencephalon, midbrain, and brainstem, almost always include oculovestibular abnormality, and motor signs are often asymmetrical in a supratentorial etiology. A cranial palsy is usually present, and bizarre respiratory patterns usually seen in the infratentorial etiology. So we have to look for the features of coning. So first, uncal herniation. This is the uncal herniation and central herniation, cingulate herniation, that's subfalcate herniation, upward transtentorial, tonsillar. These are the 5 herniation syndromes. In uncal herniation, there will be ixalated dilated pupils because of compression of the unilateral third cranial nerve, and contralateral hemiparesis with variable impaired consciousness, and mostly the patient will be having the decerebrate posturing. So, if the patient present in the emergency room with the insulated dilated pupils with decerebrate posturing, we have to keep in mind about the uncal herniation. We have to give raised ICP like immediately intubating the patient, giving mannitol, 3% NS, or head up position, 30 degrees head up position, those things, deeply sedation, we have to keep in deep sedation. Whereas central descending transtentorial, we will be seeing decorticate posturing with mid-size fixed pupils, and usually the person with early coma with chain stop breathing. Whereas the central ascending transtentorial, they have nausea, vomiting, and stupor. Whereas in subfalcine cingulate herniation, they will be having small reactive pupils and headache and contralateral leg paralysis. Whereas tonsillar, they will be having hypertensive bradycardia, bradypnea, and coma and respiratory arrest. Mostly they are having apnesis type of breathing pattern. So next thing is whether it is the features of coning. Suspect primary brainstem lesion, the having brainstem damage because of infarction or hemorrhage, a cerebellar hemorrhage, a cerebellar infarct with compression. All these three are the surgical emergency. It is a bihemispherical lesions. If no signs of brainstem dysfunction, suspect bispherical lesion and maybe structural or metabolic or toxic. So how to differentiate between the structural and metabolic? If there is underlying illness, mostly seen in the metabolic cause, that is CLD and CKD patients and diabetic patients and thyroid illness, will be seeing some underlying metabolic cause. Whereas onset is usually abrupt, that is hyperacute in the structural cause, and metabolic cause is slowly progressive, takes time, except hypoglycemia. And examination usually is asymmetric and mostly is focal, and is metabolic is bilateral diffuse, and course will be non-fluctuating, and metabolic you can see fluctuate the waxing and waning course. The respiration pattern will be normal in the structural cause, except in rise ICP causing herniation syndromes will be seen in respiratory pattern abnormalities. Metabolic cause will be hyperapnea is the most common respiratory pattern. Pupils will be normal or abnormal based upon the ICP or in herniation syndromes or at the level of lesion. The metabolic cause mostly will be normal, and ocular motility may be affected. Metabolic cause will be normal, and involuntary movements will be present or absent. If they are having cortical involvement, will be having seizures. The metabolic, mostly asterixis, tremors, and myoclonic jerks will be seen. So the causes of coma, structural cause, trauma, rise ICP, diffuse axonal injury, concussion, infection like meningitis, encephalitis, abscess, cerebral malaria, can also and demyelination syndromes, hydrocephalus, venous encephalopathy, seizure disorders, vasculitis. These are the structural causes. Other non-structural toxic metabolites, hyperglycemia, renal failure, hepatic failure. Electrolyte abnormalities, mostly sodium and calcium hypercalcemia, one of the cause will be ruled out. Mostly in the elderly patients, in the initial ABG, we can see that ionized calcium will be elevated and normal anion gap. So mostly they will be suspected secondary to the malignancy and vitamin D intoxication and hypoxia, hypercarbia, porphyria can also rare cause of altered sensorium and drugs and toxins. So mnemonic AEIOU tips: A for alcohol, acidosis, ammonia, and erythemias. A for electrolyte and endocrine causes. Endocrine causes like Edison's disease, hypothyroidism, hyperthyroidism. You have to rule out infections, oxygen hypoxia, or overdose or opiates, uremia, trauma, temperature, hypo and hypothermia, and insulin hypo and hyperglycemia, poisoning, and psychiatric disorders, stroke, as per stroke, seizures, syncope, face occupying lesions, shunt malfunctions. So based upon the time of presentation, we can differentiate between the hyperacute, mostly in the seconds to hours. Intrinsic, mostly the primary is the stroke, intraparenchymal hemorrhage. Whereas extrinsic is because of opiate overdose and hypoglycemia. Whereas presentation is acute, that is mostly in days. Metabolic hypoxia and hypercapnia, infections like encephalitis, structural like subdural or Rett syndrome, toxins like ethanol, methadone. In subacute, that is weeks to months, rapidly progressive dementia, that is prion disease, autoimmune encephalitis, CNS vasculitis. Whereas subacute meningoencephalitis will be seen in tuberculosis and fungal meningitis and sarcoid or leptomeningeal carcinomatosis. Whereas chronic, that is years to decades, dementia, at Alzheimer's, vascular dementia, and Parkinson's syndromes. These are the causes of, we can classify the causes of altered sensorium based upon the time of presentation. So what are the routine investigations to be done? So we have to first and foremost, we have to look for the GRBS, we have to look for hypoglycemia or hyperglycemia, adrenal function test, liver function test, arterial blood gas analysis, and electrolyte imbalance like sodium, hypo and hypernatremia, and calcium levels, and thyroid function test, and neuroimaging. The structural causes which can mimic metabolic cause, that is bilateral involvement, that is the subarachnoid hemorrhage, sinus thrombosis, bilateral SDH, and multifocal diseases like vasculitis and ADEM and meningitis. They can present with metabolic cause, that is bilateral and symmetric involvement. Whereas metabolic causes which can be associated with the focal features, that is hypoglycemia, hepatic encephalopathy, hyponatremia, and barbiturate overdose and lead poisoning. So non-convulsive status, look for the subclinical eye signs, the nystagmus and motor signs and fluctuation sensorium. And we have to diagnose by the EEG. So this is the basic algorithm. First, assess the airway, intubate if this is less than 8. Assess the breathing and maintain saturation more than 90%. Assess circulation, maintain MAP more than 70 mm Hg. If we are suspecting in trauma, immobilize the cervical spine. And we have to draw the blood sample for the glucose, electrolytes, ABG, liver function test, thyroid profile, complete blood count, and toxicology screen. And neurological examination, quick for the pupil, brainstem reflexes, and motor responses. If we are suspecting DICE recipe, we have to do immediate hyperventilation, mannitol, or 3% NS. You have to give thiamine 100 mg IV followed by glucose. If the GMB is less than 60, or any alcoholism or malnourished patients, and we have to suspect nalox opioid. If you suspect opiate poisoning, you have to give naloxone, dose of 0.4 to 2 mg IV every 3 minutes, or continuous infusion 0.8 mg per kg per hour. Flumazenil, if you are suspecting benzodiazepine overdose, dose of 0.2 mg per minute, maximum dose of 1 mg, and gastric lavage with activated charcoal if drug intoxication is suspected within 1 hour, or head CT if structural cause suspected. And we should take detailed history and systemic examination, that is last known at baseline, details at even onset, that is history of fever or any poison, any tablets, that is opiate tablets or SSRIs or MAVA inhibitor drugs, or consumption of the OHS, and look for the comorbid conditions like CKD, thyroid abnormalities, COPD, and medications and toxic exposures and previous such exposures, and consider EEG and lumbar function MRI at the last stage. So the coma checklist for the first 1 hour: evaluate ABC plus cervical spine, treat or exclude hypoglycemia, opioids, benzodiazepine overdose, send serum chemistries, ABG, urine toxicology screen, and emergency head CT to determine coma etiology, whether it is structural or vascular. Is the condition going to be resolved? Based upon the etiology of the injury and severity of the insult, we can prognosticate the patient. Coma is induced by the medications and metabolic abnormalities. It is reasonably to believe that the coma will resolve completely unless secondary to the hypoxia. So metabolic causes except hypoxia can have good prognosis. So reversible causes of coma, that is brain mass, SDH, EDH, ICH. If you do early intervention, acute ischemic stroke, hydrocephalus, cerebrovenous thrombosis, sepsis, venous infection, and non-convulsive and minimally convulsive status epilepticus, they have good reversible causes, in diffuse hypoglycemia, hyperglycemia, hyponatremia, hypercalcemia, hyperammonemia, renal failure, hepatic encephalopathy, thyroid storm, myxedema, and adrenal crisis, and pituitary apoplexy, and venous encephalopathy. They have usually good prognosis if treated early. So these are the factors affecting prognostication. First and foremost thing is the age of the patient. What is the baseline GCS or core score, and neurological examination of the patient, and EEG and serum biomarkers. What is the cause of that? Is hypoxic encephalopathy is a cause that is having bad prognosis, and remaining metabolic will be having a good prognosis. And neuroimaging will help in the prognostication of the patients. The prognosis in the non-traumatic coma, that is using the Levy algorithm, predict probability of a meaningful recovery 3 days after cardiac arrest. First, we have to look for both the corneal and motor reflex are reactive. Then if it is yes, then look for the verbal response. It is at least having inappropriate words, they will have better recovery within 1 year. If it is not, that is the patient is having corneal reactive, motor reactive, but doesn't have verbal response. Then if you have motor response, they have slightly recovery, but it's not up to the level of verbal response. The patient has verbal response. If the patient have both corneal reflex and motor reflex and doesn't have verbal response and motor response, they will be have little bit lower outcome compared to the verbal response and motor response presenting patients. The patient have both corneal, if the patient doesn't have both corneal and motor reflex, there will be poorer prognosis. So I'll explain that if the patient is having corneal reflex present, motor reflex present, verbal reflex present, moderate disability and good recovery within 1 year, we can see in 74% of patients, and severe disability we can see in 26% of patients. The patient is having corneal and motor response present with no verbal response, chance of recovery 33%. And if the corneal is only present and verbal response is absent, we'll be having 8% recovery. Both corneal and motor response are absent, 0% recovery. So this modified this Levy algorithm is mostly used for the post cardiac arrest patient for the prognostication of the coma. This is the post cardiac arrest algorithm, post ROSC attainment. Consider emergent cardiac intervention that STEMI present or unstable cardiogenic shock or mechanical circulator support. If the patient follows commands, other routine management. If the patient remains in comatose after post ROS achievement, we have to do therapeutic temperature monitoring, obtain brain CT and EEG monitoring, other critical care management. 33 to 36 degrees centigrade hypothermia for the initial 24 hours and rewarming of 0.5 degrees centigrade for every 1 hour for the next 24 hours to 48 hours. So this is the algorithm showing neuroprognostication post cardiac arrest. First, we have to exclude major confidence hypothermia and muscle relaxant and sedatives. If there is no brainstem reflex, any point that is pupil, cornea, and ocular supply cough reflex, we have to go for the brain death testing. If the patient is having myoclonus status epilepticus at the day 1 of post arrest, they will be having generally poor outcome. It will have a fast positive rate of 0 to 8.8%. In the during 1 to 3, if the patient is having SSCP absent N20 response, he will be having a poor outcome. It's positive predictor rate of 0 to 3.7, and in between day 1 to 3, serum NSC is more than 33 mics per liter, will be having poor outcome. The patient having pupillary corneal reflex absent, extensor absent motor response in the initial 24 hours only, you can say that is the patient have poor outcome. No need of doing all those investigations. Only 1 or 2 is sufficient. Sir,
how many slides you have?
IPS last slide, sir. Last slide. IPN.
Yeah. Okay.
So this is the long natural course of the comatose patient. If the patient is having acute brain injury, patient will be classified as acute coma. He can go into eccentric mutism or vegetative state. It's less than 1 month. If it is more than 1 month, we have to term it as a permanent vegetative state. Sometimes they rarely go into chronic coma, and other possibilities brain death. If you improve less than 1 month, you will be having minimal conscious state and chronic confusion state. Slight better in the consciousness from the vegetative state. It is minimal conscious state and chronic confusion state. If the patient remains in the permanent vegetative state for more than 1 month, after 3 months of non-traumatic brain injury or after 1 year after traumatic injury, they have generally poor prognosis. So for communication after breaking this comatose patients, we have to follow a spikes protocol. First, we have to make a adequate setup and make a perception. We have to know what the patient attenders know about the patient condition, Next, we have to invite the patient attendants whether they have any doubts. Then we have to share our knowledge in a bit by bit and show empathy that we should moral support. And finally, we have to give strategy like that the patient had a reversible injury, so no chance of recovery. Long-term goals like breakfast meat, effective feeding, prevention of physiotherapy to prevent contractures. We have to explain those things. Thank you.
Thank you, Ganesh. Very extensive and evaluated everything on a coma patient, how to evaluate under different scoring systems. Any questions?
Thank you, Dr. Ganesh. That was excellent. And we have a patient. Basically, these are all theoretically. The practical point of when it comes, we have a patient who was a 25-year-old patient presented with unconsciousness in a mango tree polamlo. So then he came to us and immediately he was unconscious, so we intubated, airway, breathing, circulation achieved. Then we have done a CBC, RFT, LFT, and then immediately we have done a CT scan, which is normal, and we are sent for a urine analysis, and which has shown that as you know that most of the patients these benzodiazepines will come as a positive. Then how to approach this type of patient, Dr. Ganesh?
Sir, sir, mostly we can suspect porphyria also, sir. Young patients.
Huh?
Sir, we can suspect porphyria, sir. Porphyria, benzodiazepine overdose, stimulating.
Porphyrias,
Can,
usually how is the presentation, porphyrias?
sir, seizures and acute abdominal pain and weakness.
He doesn't have any. Usually they come with acute abdominal pain, but
Yes, sir.
abdominal pain
Mostly
they
the
will not.
triggering factor will be benzodiazepine, sudden consumption of alcohol or benzodiazepines. Suddenly they can.
Usually benzodiazepines, usually without this also, usually it will be positive because they give some midazolam and intubate in the ER. Then they send for a urine analysis because of this one. So even they don't give also these benzodiazepines are positive in most of the hospitals, urine analysis.
Yes, sir.
So how will you approach
Use
them?
approach, sir. Patient will be having features of benzodiazepine toxicity, sir. Unconscious patient. Flumanazine, you can give trial of flumanazine 0.2 mg to 1 mg, and just only conservative management, so mostly in 1 or 2 days will be when the drug will be metabolized outside from the body. When the drug is
Can
metabolized,
we,
sir,
so we also have sent for multiple things like serum cholinesterase levels to rule out OP poisoning, and if this patient is having a subclinical seizures, so we have done an EEG.
సురేంద్రనాథ్ కరెక్ట్ చెప్పాడు కదా స్నేక్ బైట్ గురించి.
sir, snake bite, sir. Snake bite is one of the cause. We have to look for
Snake
the
bite.
snake bite, snake
So
mark.
we have picked for the snake bite. So how will you diagnose it? Snake bite.
Sir, listen, we can see two types, neurogenic and hematologic, sir. As the patient had neurological features, we have to look for localized signs of snake bite, sir. That is
We
any
have.
cellular.
So quickly I'll finish off this one. So we have checked into all. Then we thought of the alcohol intake, and finally this all has almost. Then we have gone into the checklist of what are the causes of coma, because we are not able to identify what is the cause. So after 6 or 7 hours, then finally most of the causes were ruled out. Then we have given a dose of ASV for this patient, almost 24 hours or something. I think after 48 hours, he became conscious. And meanwhile, we have done also MRI. There is no major role in MRI, but still posterior fossa issues are there, then we have done an MRI. MRI also did not show anything. We have done a nerve conduction studies. Even though GBS will present with consciousness, but if he's all the limbs are flaccid, so even that nerve conduction studies are, I think, slowing was there, but we cannot say it's a GBS because GBS patients will be conscious. So even muscle weakness is there. So finally, we have given ASV, and after 2 days, he became conscious, and we extubated that patient. After that, he came. He told us that it's a snake bite.
Yes, sir.
Yeah, we have a similar 2 cases.
Mm.
Yeah, we found unconscious in the house.
Mm.
So, finally, we gave ASV, then he recovered.
And we had a
అలాంటి
patient.
నీకే దొరుకుతుంటాయి డేవిడ్.
Huh?
అలాంటి స్నేక్ బైట్ కేసులు నీకే వస్తుంటాయి.
Yeah.
కనెక్షన్స్ ఎక్కువ అక్కడ వైపు ట్రీస్ కదా, మ్యాంగో ట్రీస్ అన్నారు కదా.
సార్ కనెక్షన్స్ టాప్ గన్ దగ్గరికి పోతాయి సార్ పేషెంట్స్, కాంప్లికేటెడ్ కేసెస్.
ఇంతకుముందు మాకు వచ్చాయి, ఇప్పుడన్నీ మా ఎక్కడ రాణిస్తున్నారు, అటు నుంచి అటు హనుమాన్ తాకు నుంచి అయస్కాంతం లాగేస్తుంది, లాగి పడేస్తుంది.
So we also have seen alcohol toxicity also, sir. Severe metabolic acidosis was there, and then we have to ethanol toxicity. So when you different presentations, I think Ganesh, excellent presentation. You can put an algorithm, Dr. Ganesh, so that all the juniors and even seniors also, we will also no need to refer into textbook. We can just go and evaluate in that way. Thank you.
Okay, sir.
Another issue in an unconscious patient, particularly in a cardiac, there is a dictum that patient, old man comes in unconscious state, having ST elevation or ST depression. You should not immediately give thrombolysis, suspecting there is MI or not. Once the patient is unconscious, unless otherwise patient come in shock or malignant arrhythmias, first you rule out the stroke.
Yes, sir.
Even SAH, there comes with severe ST depression or ST elevation. We had one patient long back, came in unconscious state with profuse sweating. They took ECG and thrombolyzed, and patient immediately within 5 minutes patient developed cardiac arrest due to a massive cerebral bleed. So this is because of ST elevation is because of subarachnoid hemorrhage, not because of ST elevation MI. So that patient died. So in a old patient comes in unconscious. No cardiac patient, MI patient or ischemic patient comes in unconscious state, unless otherwise patient had cardiac arrest or malignant arrhythmia or cardiogenic shock. Rule out stroke, then you decide the treatment.
Maybe probably severe headache with MI కూడా చేయాలేమో సార్, ఎందుకంటే SH sometimes may not present with unconsciousness. So severe worst headache plus ST elevations, I think అది కూడా చేయాలేమో అనుకుంటాను. డేవిడ్ సార్,
పేషెంట్ అన్కాన్షియస్ స్టేట్ లో వచ్చారా?
అదే అంటే అన్కాన్షియస్ లేకపోయినా సివియర్ హెడ్ వర్స్ట్ హెడేక్ అండ్ ST ఎలివేషన్స్ ఉన్నాయి అనుకోండి, సో అప్పుడు కూడా ఒకసారి CT బ్రెయిన్ చేసుకుంటే బెటర్. బికాస్
definitely, but patient unconscious
ఇది
with
డెఫినెట్లీ
ST elevation,
yes sir.
No MI patient will develop unconscious state.
Yes, agree sir.
Yeah. Any questions? There are no questions. Time is over. We'll close the session. Thank you, Ganesh. Please share the PPT in the group.
Okay, sir. Okay,
And
sir.
if possible, form a checklist of a comatose patient, so that it will be useful for all the hospitals in the casualty. Thank you very much for a nice presentation. Yes, sir.
Yeah, thank you, sir.
Thank you.